Welcome to the next one of our series of videos for Geeks 4, looking at the topics that we're going to cover. So when you come back here, you might think, well, yeah, this is a normal looking esophagus. Maybe you put a bit of steam on the lens or something and you just pull out, right? Esophagus examined and gastroscopy done. But that's not the case here. So let's have another look. But maybe this time we'll do the pullback in MBI. And actually you may have just sneakily noticed something there as I passed it, but let's try and just see if it's more obvious when we pull back. So there's something wrong with the esophagus. There's very clearly something wrong. It looks a little bit maybe bumpy. It looks a little bit nodular. There's maybe, when you look in the background, some kind of surface adherent fibrin indicating that potentially there's some inflammation there. And then as you come back more, you start to see more of the same. And then there's something very, very clear on narrowband imaging or virtual chromoendoscopy here, which was not visible easily in white light. So let's push by it again in white light. So let's come back. And while it's now probably obvious and clearly there, and I'm also, by the way, using a cap that makes it more obvious, it's much, much more obvious in MBI. In this example with a Olympus 1500 endoscope. So what is it? Well, it's in the mid-esophagus. So the top of it is sitting around 25 centimeters from the incisors. It's very difficult to define its borders, I would say. You will have to spend a bit of time doing so because this abnormality is not just here. So this is the most obvious part of it, but it definitely extends down here. And then the question is how much further that it extends and how much of the circumference is involved by this lesion is still to be determined. But indeed, so the patient's on their left side. This is probably the 3 o'clock that it's focused on here. And it's very irregular and abnormal. We can look at it in white light and just get an overview. And we can see that it is potentially a little bit deforming the lumen, but not a lot. There's no stenosis associated with it. And there is some surface nodularity to it. So if you are taking our approach to the imaging of lesions found in the upper gastroesophageal, gastrointestinal tract, then you will know that our approach is to look at the underlying structure, and that you can do by using narrowband imaging, and think about whether the structure is regular. So I might show you a regular structure by coming up here and just looking at something like this, where you know, there's all sorts of little blood vessels there. You can see them here in the 12 o'clock. They're all regular. They're all pointing in the same direction. Is it losing its structure but with some maintained structure, or is it completely irregular? And so for that, in this case, we are talking about the IPCL classification, or the intra-papillary capillary loop classification. Water jet's not working. So we are looking at the shape, the dilated nature of those, and whether they're all in the same direction or not. And so here, at the very least, you have a disordered pattern of those blood vessels, and they are more dilated, and some of them skip more than one loop. So certainly that this is a lesion of concern, and if you are performing a procedure where this is detected, the simple things that you might want to tell your multidisciplinary meeting or your friendly intervention endoscopist plus or minus surgeon is, well, where is it? So it's in the middle of the esophagus. What location is it in, or part of the circumference is involved? So here we're thinking it's definitely at least half, if not more, from the 12 to the 6 o'clock. And what degree of disruption is present here? So kind of, it's relatively flat, this thing. But that you see that the architecture is completely disordered. And then the most important thing is some great pictures, right? So this is not a great picture. It's in the distance, it's far away, and you might say, well, you've got a patient with anesthetic and you've got the best scope in the world, and all those things are probably true. However, we can strive for better, even if better is not, or excellence is not possible in the context in which you find yourself in. And so if we really inflate and then we stop here, then we have an image which centers the lesion where we think the actual positioning in the esophagus is relative to the stomach. We have the lesion right on the 3 o'clock, and you can see the morphology of it in an overview. Then it might be useful to take some photos or even a video where the underwater, or even if you don't have underwater, just use a cap to get a nice image of the sort of structure that we're looking at. So this is not ulceration, and we can demonstrate that by then if we go underwater, we need a bit more water jet power there maybe. So this is important. Your water jet needs to be not too powerful, but not too little power. Of course, if the patient's under anesthetic, then you might want to have them intubated for this sort of thing. Here you go, you can get this great image of the microstructure, and you're looking for the part of the structure which is the most disordered, right? So we're not just going to take a photo up here and be like, okay, well that's not useful. The most useful part to make the decision is the part which is the most disordered. So here you see some loops which are maybe actually relatively normal, even maybe just inflammation on the edge of the lesion, because they are kind of swimming in the same direction, and even just a little bit dilated from normal. But here, this area is the most abnormal part of the lesion, and you can see that the loops are completely disordered and a little bit dilated. So this is the sort of thing and the sort of image you might want to try and provide to your multidisciplinary team. And then, of course, we can talk probably all day about the pros and cons of endoscopic resection of this lesion, but here we will endoscopically resect this and send it for histopathology. All right, so thanks very much for watching. I want to summarize that by saying that you must do your pullback in the esophagus either very slowly or preferably using a enhanced imaging technique. What you find, you must take nice images of which show the extent of and slightly discuss the microstructure and whether it's regular, irregular, or completely irregular. And you must then take a biopsy of such a lesion. I'm not going to do that now, but if you find this, you must take a biopsy, and you must therefore discuss it with your local multidisciplinary team for expert management. And this probably is the site of a biopsy that was taken previously. All right, thank you very much for watching. Come and see us in October online, 5th and 6th of October, geeks.com. Thank you very much.